Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Aviraz. Here in this video, we will be discussing about respiratory infections, pneumonia, and tuberculosis. So pneumonia is infection of the lungs and it has three patterns: lobar, bronchopneumonia, and interstitial pneumonia, which is atypical pneumonia. So lobar pneumonia is a classic form of pneumonia, commonly caused by Streptococcus pneumoniae. Bacteria is acquired in the nasopharynx, and then it is aerosolized to the alveolus. It enters the alveolar type 2 cells and then it multiplies in the alveolus, invade the alveolar epithelium and pass from one alveolus to next through the pores of cone. And then it causes inflammation and consolidation of that entire lobe and can even involve entire lung sometimes. Here we can see the specific involvement of one lobe of the lung, that is the upper lobe. So it is called as the lobar pneumonia. So there are four stages in the lobar pneumonia. So the number one stage that occurs in the first 24 hours is the congestion, where the alveolar capillaries dilate and there is exudate of bacteria that is developed there. And then for the next 2 to 3 days, there is rare hepatization, where there is exudate of RBCs, neutrophils, fibrin. The fresh exudate contains the RBCs and WBCs which are intact, that are not broken down. Pneumococci are alive and the lobes look red. The gray hepatization that occurs in the next 4 to 6 days is gray, and the lobe is formed. There are exudates with neutrophils and fibrin. The RBCs here are disintegrated. In the red hepatization, it were intact. There is dying pneumococci, and in the red hepatization, it was alive. And then comes the resolution phase, where there is return to normal with little scarring. The enzymes digest the exudate, and the type 2 pneumocytes are the key for the regeneration stage or the resolution stage. So 55-year-old man presents to the emergency department with sudden onset of fever, productive cough with rust-colored sputum, pleuritic chest pain, and dyspnea. On physical examination, decreased breath sounds and crackles are heard over the right lower lung field. Chest X-ray reveals consolidation of the right lower lobe. Which of the following best describes the stage of lobar pneumonia seen in this patient? Congestion, red hepatization, gray hepatization, or resolution. So the patient's presentation with sudden onset fever, productive cough with rust-colored sputum, pleuritic chest pain, dyspnea, and findings of consolidation on chest X-ray are consistent with lobar pneumonia, specifically in the red hepatization stage. The red hepatization is the second stage of lobar pneumonia following the initial congestion stage. In this stage, the affected lobe becomes red and formed due to the presence of abundant neutrophils, erythrocytes, and fibrin within the alveolar spaces. This results in consolidation of the lung tissue and loss of air spaces. The sputum may appear rust color due to the presence of blood. Then comes the bronchopneumonia, where there is patchy inflammation of multiple lobules. The primary involvement is the airways and the surrounding interstitium, and it is commonly caused by Staphylococcus aureus. Here is the X-ray of the bronchopneumonia. The interstitial pneumonia or atypical pneumonia is when the inflammatory infiltrate of alveolar walls is only there. It has a more indolent course, may be caused by viruses or Legionella pneumophila, Mycoplasma pneumoniae, or Chlamydia pneumoniae. So atypical pneumonia, so the pneumonia caused by these following organisms, usually milder than Streptococcus pneumonia. The respiratory distress is rare, and there are interstitial infiltration on chest X-ray, also called as walking pneumonia, because the patient just walks into the OPD, or the patient does not know that he is having pneumonia, so it is called as atypical or walking pneumonia. So the causes of pneumonia in adults. So Streptococcus pneumoniae is the most common, and then comes the Haemophilus influenzae, Mycoplasma pneumoniae, and then we have the Legionella and some gram-negative rods like Klebsiella, E. coli, Pseudomonas, and there are some uncommon causes also that are presented there, and which are often isolated in hospitalized patients like Staph aureus. Okay, so anaerobes can also cause pneumonia, some viruses like the respiratory syncytial virus in children, and influenza may be the cause of pneumonia in case of children now. So the clinical classes of pneumonia are there. So there are community acquired pneumonia, and then there is a nosocomial pneumonia. So the community acquired pneumonia is usually caused by Streptococcus pneumoniae, Haemophilus influenzae, and Staph aureus, and sometimes maybe by Legionella or Mycoplasma, which are called as atypicals. So the nosocomial pneumonia are generally caused by some bad bugs, like often gram-negative, like Pseudomonas, Klebsiella, E. coli. They may be hospital-acquired ventilator-associated pneumonia or healthcare-associated pneumonia, which can be acquired through nursing homes. So the Legionella is the infection from inhalation of aerosolized bacteria, which are not airborne, and the outbreaks can occur at hotels with contaminated water. So if the question gives you a hint about the patient having a history with exposure to contaminated water, maybe at some hotels or some nursing homes, then it may be the Legionella pneumophilia may be the cause of the pneumonia. It can cause nosocomial pneumonia in nursing homes, and initially the patient has mild pneumonia symptoms. So the fever is mild and the patient only have the slightly productive cough. It can progress to severe pneumonia, and the patient may also have GI symptoms. The patient may have watery diarrhea, nausea, vomiting, due to which the patient generally have hyponatremia, which is very, very common. So mm, the person has history of stay at hotels with contaminated water, nursing homes, plus there's hyponatremia, plus with pneumonia symptoms, then you have to think of Legionella as a cause of the pneumonia. So there are some special culture requirements for Legionella. So it does not gram stain well. So it is buffered in the charcoal yeast extract agar. Iron and cysteine is added for growth. Thus, it is supplemented with antibiotics and silver dyes. So antimicrobials prevent the outgrowth by competing organisms, and dyes give distinctive color to Legionella. We can also perform urinary antigen test, which is a rapid test available in minutes, and it does not test for all Legionella subtypes. That is one drawback of the urine antigen test, but we can still perform that. So the classic cases generally have mild cough, watery diarrhea, confusion due to low sodium, negative bacteria and gram stain, diagnosed with urinary antigen test, and the treatment of Legionella is by fluoroquinolone or azithromycin. So 45-year-old previously healthy woman presents to the emergency department with a fever, headache, myalgia, and non-productive cough. She recently returned from a business trip where she stayed in a hotel. On examination, she appears ill and febrile. Chest X-ray reveals patchy infiltrates in the lower lobes bilaterally. Urinary antigen testing is positive for Legionella, which of the following is a common complication associated with Legionella pneumonia. Pleural effusion, lung abscess, empyema, pericarditis, or pulmonary embolism. So pericarditis is a common complication associated with Legionella. So the other may be pleural effusion, lung abscess, empyema, okay, which can occur, but these are less common. The most common complication that can occur with Legionella pneumonia is pericarditis. So this can lead to chest pain, pericardial effusion, and potentially cardiac tamponade if not treated. Now let's dive deep into tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis, which is an obligate aerobe which prefers the lungs. Reactivation disease prefers upper lobes. It is a facultative intracellular pathogen and it infects the macrophages. So these are the typical characteristic of Mycobacterium tuberculosis. Acid fast, these mycobacteria are acid fast. The cell walls are impermeable to many dyes, stained with very concentrated dye plus heat. It has the lipid soluble, contain phenols. Once stained, plate rinsed with acid decolorizer. So it is called as acid fast stain. The TB resists the decolorization with acid solvents. Some other bacteria like Nocoria can also show acid fast staining. So the primary TB, so mainly a disease of childhood or chemo patients, due to the ineffective immune response. So gradual onset is up to weeks. The patient presents with fever, cough, pruritic chest pain, fatigue, and arthralgias. So the first week, the TB infects the macrophages. It is phagocytosis, and there is intracellular bacterial proliferation. Okay, since there is a defective intracellular killing, there is intracellular bacterial or tuberculosis proliferation. In the next 2 to 4 weeks, there is cell-mediated immune system which controls the TB. There is Th1 response, activation of CD4 plus T cell, and interferon gamma is secreted. And then there is the activated macrophages and cytotoxic T lymphocyte that comes in place. And then there is the formation of granuloma. So granulomatous inflammation and case-eating necrosis is there in case of TB. Okay, the macrophages transformed into epithelial cells, Langerhans giant cells, fibroblasts are activated, which form the collagen, and the T cells mediated delayed type hypersensitivity or type 4 hypersensitivity reaction is there, so which is very important, most common reaction in the examination. And here is the typical picture of granuloma that is there. Now, the chest X-ray is often normal, and the classic finding is hilar lymphadenopathy. It occurs as early as 1 week after infection and resolves slowly over months to years. So resolution, so most 90% of patients control infection, disease heals, leaving fibrosis, sometimes completely clears, and usually enters the latent phase, and then the immunity develops, but the patient is PPD positive, which is purified protein derivative positive. Rarely 10% of patients have expanded illness, can go into miliary dissemination, where it is called as miliary tuberculosis, and more common with HIV, CKD, and diabetes mellitus patient because they have very impaired immunity. So if there is exposure, there can be three things. There can be infection, which can be clear on its own. The infection is contained, which may be latent, and then it can reactivate as a reactivation TB, which can transform into miliary TB. Or there can be primary tuberculosis infection, and it can transform into miliary tuberculosis, or it may go into a latent form. So PPG testing is very important testing, which is generally action examination. We generally don't do it to diagnose, but to just screen the patient sometimes, or for some travel purposes. So we just inject a few ml of, or you can say 0.01 ml of PPD in the subcutaneous area, and then we measure the induration. Okay, so if the induration is less than 5 mm, then it is negative. More than 5 mm, positive if the patient is HIV or immunocompromised. If it is more than 10 mm, then that means the patient is a high risk individual. And if it's more than 15 mm, it means that the patient may be an active case of TB. So the treatment of active TB requires multi-drug regimens like isoniazid, rifampin, pyrazinamide, ethambutol. Sometimes the streptomycin injection can be added. Sometimes the patient has to go in direct observation therapy dots, and the risk of multi-drug resistant TB is also there. So TB key points, take home points, is that the mycolic acid cell walls are acid fast. It infects the macrophages. There is delayed type 4 hypersensitivity reaction. It has viral lymphadenopathy and Ghon's complex. There is reactivation in the upper lobe in case of immunosuppressed individual. Latent infection diagnosed with PPD. Treat latent disease with isoniazid and treat active disease with multi-drug regimen. So the latent disease is treated with isoniazid. Very important key point you need to remember and can be action examination. So a 60-year-old man presents to the clinic with a 3-month history of fever, night sweats, weight loss, and fatigue. He also complains of dry cough and shortness of breath and exertion. On physical examination, there are fine inspiratory crackles bilaterally. Chest X-ray shows diffuse small nodular opacities throughout the both lungs. Acid-fast bacilli staining of sputum is negative. What is the most likely diagnosis? Bronchiectasis, sarcoidosis, miliary tuberculosis, pneumocystis jirovecii pneumonia, and pulmonary eosinophilia. So yeah, the diagnosis is miliary tuberculosis. So the clinical presentation of a 60-year-old man with a history of fever, night sweats, weight loss, fatigue, dry cough, and shortness of breath on exertion, along with physical examination findings of fibrous inspiratory crackles and chest X-ray showing diffuse small nodular opacities throughout both lung fields, is highly suggestive of miliary tuberculosis. So miliary TB is a form of tuberculosis characterized by disseminated hematogenous spread of Mycobacterium tuberculosis bacilli, resulting in the formation of multiple tiny granulomas in various organs, particularly in the lungs. The clinical features of miliary TB include constitutional symptoms such as fever, night sweats, and weight loss, along with respiratory symptoms such as cough and dyspnea. And that concludes our video on respiratory infections.